So far, no one's booed me out of the room. So, let me begin. History of oncology in Arkansas, 1977 to 2025, or the present. I always start with this. Senator Matthew Neely, 100 years ago, on the Senate floor, gave this speech. I propose to speak of a monster that is more insatiable than the guillotine, more destructive to life and health and the mightiest army that ever marched to battle, more terrifying than any scourge that has ever threatened the existence of the human race. The monster of which I speak has infested and still infests every inhabited country. It has preyed and still preys upon every nation. It has fed and feasted and fattened on the flesh and blood and brains and bones of men and women and children in every land. The sighs and sobs and shrieks that it has extorted from perishing humanity would, if they were tangible things, make a mountain. The tears that it has wrung from weeping women's eyes would make an ocean. The blood that it has shed should redden every wave that rolls on every sea. The name of this loathsome, deadly, insatiate monster is cancer. How much has changed in 100 years? That's this lecture. So looking back, this is sort of an autobiography of my career in Arkansas, as I remember the amazing changes that have occurred in cancer care and what part I believe I played in it. Honestly, I'm very proud of my medical career and what part I played in advancing cancer in Arkansas. And to be honest with you, it may sound, as I do this lecture, that I'm bragging, but I'm honestly telling you the truth of these years. So I started my practice in July of 1977 in Little Rock, Arkansas, having finished my medical oncology training at the MD Anderson Cancer Center. That's what I looked like in 1977, and I look back at that and I go, what doctor in their right mind would have sent their cancer patient to someone that looked like that? But honestly, back then, everybody that was 30 looked like that. We all had long hair. We thought we were the Beatles. And we had long sideburns. But I threw this picture in just to show you what I looked like. So looking back, and this is one of the things that I always say, at that time, I was actually the first and only fully trained medical oncologist in all of Arkansas. Prior to me coming here, there were some hematologists, never trained in oncology, because they gave the drugs for acute leukemia and maybe some lymphoma patients. Doctors tried to call them to see their cancer patients. But they didn't do lung, they didn't do breast, they didn't do colon, and it was very frustrating. If a doctor in Arkansas had a patient with cancer, basically they sent them down to MD Anderson in Houston or to the Baylor cancer place in Dallas. There was really nobody practicing oncology when I arrived. So, this is the story of how oncology has advanced over 50 years, and so much of what you're going to hear today, you as internal medicine residents, you take it for granted. And that's the purpose of this lecture, is for you to understand how much has truly changed. Well, in the beginning back then, the practice was very different. Most of you, when you finish your residency or your fellowships in whatever subspecialty, you will probably join an established practice that has a number of other doctors in your field, or you'll be part of a hospital system, or you'll be part of a national group. I mean, you really come out and automatically you're going to be successful, you're going to get patients. When I came up here in 1977, July of 77, I started my own practice. I had nothing. I had no help. I had no money. I literally came up here I had spent my last dime. I had a wife, I had 2 children. I had nothing. All I had was a dream. Interestingly, what happened is I decided to go out in private practice. I was supposed to be going to Columbia, South Carolina. I had already resigned my position at MD Anderson. I was already on the teaching faculty and the staff. And listen to this story because I want you to hear it. When I said to them I was coming and I resigned from MD Anderson, one day I said to them, so when are you going to send me the contract that has in it all you promised me? And they said, oh, well, in the South here, we don't have contracts. Gentlemen don't need contracts. And I said, you know, I may be 29, almost 30, but I'm not stupid. I mean, if you don't send me a contract, I have no expectation that you'll keep your promises, and I'm not coming. And so here I was, it was a Tuesday, I'll never forget, it was a Tuesday. I canceled with them. I already had no job in 90 days. I had a wife and 2 children, and you would have thought I would panic, but I didn't. Because in those days, there were no medical oncologists in the whole country. So I went to a conference that afternoon, and I was speaking with one of my professors, asking her if she knew of any jobs in private practice. And she was actually telling me about the Baylor Cancer Center. And as she was telling me about it, a doctor from Little Rock, from a place called Carti, and I'll explain what that is in a moment, walked up to her and said, Nylene, it's so good to see you again. I haven't seen you since I finished my MD Anderson rotation. He was a radiotherapist in Little Rock. And she looked at him and said, oh, Alva, I heard you guys in Little Rock were looking for a medical oncologist. I want to introduce you to Dr. Jack Sternberg. And he said, he looked me in the face and he said, well, you know, the radiotherapy doctors here told me you were the best guy to try to recruit, but you're going to Columbia, South Carolina. And I said, well, that was true, but as of 30 minutes ago, I'm no longer going there. And he said, then we'd like you to come and look over Little Rock, Arkansas. So that was a Tuesday, and I flew up to Little Rock, Arkansas 3 days later on Friday. I loved the city, and I'll explain to you what I discovered about the medical community at that time in Little Rock. And that's how it all started. And they put me together with Doctors Hospital, which no longer exists. And again, listen to this story. They guaranteed me a salary until I was on my feet and didn't need it any longer. Well, within 6 weeks of starting my practice, I had made more money than I was making as my entire salary for the entire year at MD Anderson. And I told them I no longer needed them to help me out. And it was at that point they said, oh, okay, so when are you going to start paying back the loans? And I said, what loan? And they said, well, you didn't think we were just giving you the salary. You must not have read the contract you signed with us. And I said, I guess I didn't. In the fine print, I had no idea this was a loan I had to pay back. Well, fortunately, it didn't take 9 months before I was solvent. But so what I had to pay them back was very little. But the reality is I want all of you to hear this also. Whatever contract you sign, have a lawyer look at it and make sure that you know what you're getting yourself into. So, what was Carti? Carti in the 60s, well, let's talk about radiotherapy because Carti was a radiation therapy institute. In the 1960s, each hospital had their own cobalt machine. You probably don't even know there was such a thing. And it looked like this. Cobalt was a radioactive substance, and it was very imprecise. You couldn't change how powerful it was. At that time, All of your planning was done with just plain old x-rays. It really was lousy, but it was the best that they had. And when you hear the stories of people being horrifically burnt, that was the days of coal. 10 years later, each hospital in Little Rock and throughout the country had their very own linear accelerator that could actually change the strength of the beam to be relatively superficial versus very deep. But a separate machine was actually necessary to do the new type of treatments that modern radiation therapy was now doing, and you couldn't do things like electron beam. No one treatment machine back then could do what was all needed, and only cancer centers like MD Anderson, Memorial Sloan Kettering, Roswell Park Memorial Institute in Buffalo, only they had all the machines necessary. So what happened? CARTI, Central Arkansas Radiation Therapy Institute. All Little Rock hospitals, someone came to them, and I don't remember who it was, and said to them, all of you need to give up your machines. We'll build a building and put all the machines, just like MD Anderson, into it, but it'll be separate from each hospital. And lo and behold, you don't expect people to actually do what's necessary and intelligent and logical. All hospitals gave up their radiation therapy machines and their radiotherapists, and they all went to this new building, which had multiple radiotherapists, 2 of which were from MD Anderson, like I was. It was called CARTI, and they recruited me, like the story I told you a moment ago. So, what's the difference now? Now, in 2025, one machine can do all that CARTI's many machines could do in 1976. Now, instead of using X-ray to plan out where the beam is going to go, every patient, the planning is done by computer-assisted radiotherapy planning, CT scan, for amazing precision. And because of it, the amount of radiation that gets to non-cancerous tissue is dramatically less. And less people are saying they got horrifically burned. Now, if it's head and neck cancer, when you have to do the throat, they still get badly burned. But basically, prostate, rectum, breast cancer, lung cancer, the amount of other tissue that's not cancerous is at a minimal. And then today, because of these machines, you have probably heard of IMRT, which is intensity modulated radiation therapy, SBRT, stereotactic body radiotherapy, and of course gamma knife radiosurgery of the brain. And basically what's happening is the machine, which now looks like this, rotates around you and constantly rotating, and very little non-cancerous tissue gets radiated because the beam is coming in from so many different angles. So that's the difference between radiation therapy. So 3 months before moving to Little Rock, when I was here, I brought my wife up the next week. Initially, she said, when I said to her, I really love Little Rock, I want to move to Little Rock, she went, Little Rock, are you crazy? They don't have electricity or indoor plumbing. And I said, oh, honey, no. It really is just like every place else. She came up the next week with me. She too fell in love with it. And at that point, in 1 weekend, we found a house that was 3,000 square feet. It was being built in West Little Rock. She sat down and chose every single color for paint, the carpeting. She did all that. I went over to the doctor's building in Little Rock. I took a 2,500 square foot office, and they said to me, well, how do you want it to look? I said, what? They said, well, you have to tell us how big is the waiting room? How big is your reception area? Tell us how many exam rooms you want. What is the exam room size going to be? Where do we put the sink? You want a chemotherapy room. How big is it going to be? And I said, I have to do that. They said, well, who else? So I sat down with a ruler that weekend, and I drew out the exact everything, every size of every room, and 3 months later, when I came back, there was my office. One of the interesting things that, again, it's a cute story, has to do with, they said to me, well, how big do you need to have your waiting room? And I said, I don't know. And they said, well, how many rhythms are you going to have? And I said, what's a rhythm? And they said, well, every patient that comes and is going to be there for 2 or 3 hours is going to bring somebody with them. and I went, oh, well, I imagine each person probably will bring 1 or 2. So I ended up having this huge waiting room that could easily sit 60 people. I mean, and plenty of times that we used every single space. So in one weekend, I bought a house. I bought an office in the doctor's building. I took out $400,000 in loans, which today would be $1.2 million. And I only knew 2 doctors in all of Arkansas. We went back to Houston, and my wife immediately broke out in hives from her anxiety of, oh my God, what have we done? But what was amazing was I had 3 banks fighting to give me the money, which would be a lot different today. They just, I assume, knew that if I was going to be the only cancer doctor in all over Arkansas, how could I fail? So at that point, I had to interview and hire staff. I had to train the nurses in how to do chemotherapy. I personally went around and I introduced myself to every surgeon that was practicing in Little Rock. Again, when you folks join a group and you're guaranteed patients, you're not going to do things like this. But back then, I thought it was necessary. Why should somebody send me a patient if they didn't know me? And everybody that I met was just wonderful. They were so thrilled to have an oncologist in Little Rock, in Arkansas. But there was one surgeon, true story, his name was Dr. Joseph K. Buckman, Sr., and he was an older surgeon. He was a difficult man. I went in to meet him, and he was in his office. He was sitting in his chair, and he looked at me in a deep Southern drawl, and he said, "Sit down, son." And I mean, so I kind of, my eyes popped open. I sat down, and he stood up, looming over me, and he said, "I just want you to understand, I've been giving that 5FU since 1955, and I know how to do oncology. And I think all of you medical oncologists are nothing but charlatans." And that was the truth. I mean, I went and I looked at him and I said, well, I hope everybody else doesn't think that. So, on 7/7/77, I incorporated Oncology Associates in Little Rock. So I started seeing patients, and different than what happens today, most patients for the first visit, you're going to see them in the exam room. That's not how you did it back then. I had a beautiful office. They and their family would come down and sit there in front of my desk. I would sit behind the desk. It was a beautiful room. And I would start the conversation, and I would say to them, well, you know, Dr. Such and Such has sent you to me so I could treat your colon cancer. And more times than I want to tell you, they would go, what? I have cancer? And I would sit there in shock, and they would sit there in shock. Well, back in those days, you didn't talk about cancer and use the word cancer. And so a lot of surgeons, not all of them, but many of them would actually not tell their patient that they took out a cancer. And they didn't know what the word medical oncologist was, the patients. And so they would come to me not knowing they had cancer that I was going to treat. And that was, I have cancer? I mean, it was amazing. Now, the first specialty boards didn't start until 1977, and that's why nobody knew what a medical oncologist was. So I started going around in Little Rock teaching a course that I called the team approach to medical oncology, or the team approach to oncology. And I was saying that it's not just one doctor. It is the surgeon or the surgical oncologist. The radiation therapist is part of the team, as is the medical oncologist, the oncology nurse, the pathologist, the radiologist, the social worker, the home health. I mean, today all of you take for granted that you can't practice medicine without all of this. But again, that was unique back then in 1977. And you say, why do you have Piper Cub? Well, the entire state of Arkansas knew essentially nothing about modern oncology. So many, many nights I would meet up with Kent Westbrook from the medical center in Little Rock. He had trained at MD Anderson. Cody Haynes, radiotherapist, had trained at MD Anderson, and myself. We would get into a Piper Cub. We would have a pilot, and we would fly to Fort Smith, to Mountain Home, Texarkana, and we would do statewide tumor boards, and we would try to explain to the doctors of Arkansas what modern oncology looked like and what we could do. And we did this very, very often, and we would not get back till 10, 11 o'clock at night, and then get up and start rounds at 6 o'clock the next morning. So, prior to 1977, all chemotherapy was administered throughout the hospitals, if there was any, by absolutely untrained nurses who knew just to put it up or drip it in, and there was no such thing as in-office chemotherapy. I convinced St. Vincent's and Doctors Hospital to have chemotherapy units or chemotherapy or cancer floors where it started. I couldn't get in to do the same thing at Baptist Medical Center in Little Rock because they had a hematologist. His name was Garnet Matthew. He said to the directors at the hospital, we are not going to have a cancer floor here because if you segregate the cancer patients, you're treating them like lepers. And Baptist Hospital for 3 years refused to have a cancer floor. But St. Vincent's did, Doctors Hospital did. I can actually tell you at one point at St. Vincent's we had 3 floors, and Doctors Hospital had one entire level, the 3rd level. That's how many cancer patients were now in the hospital getting treatment. And in my office, we began the first outpatient chemotherapy unit in all of Arkansas. So what happened next? So I realized that Blue Cross, Blue Shield, Medicare, Medicaid, and all the other insurance companies, they had no codes to go along with what we were doing. They didn't know what outpatient chemotherapy was like. They didn't, seriously, I had to sit down with all of them and tell them what I was going to be doing in the office, and we were the ones that invented the original codes for outpatient treatments. Also, the offices had to be designed for outpatient chemotherapy. So you take it for granted now, if you go over to Genesis or any of these other places, that you're going to have this beautiful room and there's going to be chemotherapy chairs. Well, I had a chemotherapy room. It didn't look as nice as this. The chairs weren't as nice. We didn't have flat screen TVs. But I had 5 chairs on one side of the room and 5 chairs on the other, and we were able to give outpatient chemotherapy to 10 patients at a time. This was absolutely first time ever done in Arkansas. So Both the hospitals and the office nurses had to be trained on how to administer chemotherapy. Initially, I was the one that trained them. Fortunately, very rapidly, they sent their nurses off to places that could train them better than I could train them. But again, in the beginning, it was me. Nurses had to be educated to be aware of the dangerous situations and problems that were unique to cancer patients, unique to patients that were on chemotherapy. I mean, there were oncologic emergencies, there were side effects to chemotherapy. Again, I had to do the initial training back then in '77. Nurses had to be educated on how to answer questions for cancer patients. Remember, in 1977, there were no nurse practitioners. You just hired a nurse and basically you trained her. She made rounds with you. She heard what you said to patients, and she became as good as any nurse practitioner over a few years. At that point, up until the time that I retired in 2006, I saw every patient, every office visit, every hospital visit. No one did things that are done today by nurse practitioners and others. Let's talk about the changes in the treatment with intravenous chemotherapy. In those days, back in 1977, we had 5-FU, methotrexate, vincristine, vinblastin, BTIC, bleomycin, cyclophosphamide. We had adriamycin, which was called the Red Devil, because patients who took that lost all their hair, threw up for days afterwards. We had cisplatin, carboplatin, etoposide. So in 1977, we basically had 16 chemotherapy drugs. And then what happened starting around 1974, the big cancer institutes said, what if we put together these drugs, and especially if they had different side effects, we could give medicines at full dose or near full dose because each one had different side effects. So then they came up with chemotherapy regimens. CMF, FAC, that was for breast cancer. COMF and VAC was for lung cancer. CHOP, CHOP, and EPIC was for large cell lymphomas. MOP and ABVD was for Hodgkin's disease. I came up with a regimen for bladder cancer, and I called it CISCA. It was cisplatin, Cytoxan, adriamycin, and then I became known as the CISCA Kid. And you don't know what the Cisco Kid was because you're too young. But in those days, everybody knew what the Cisco Kid was, and I became the CISCA Kid. Cyvadic for sarcomas, BEP for testicular cancers. So in 2006, in the middle of that slide, we then had paclitaxel, which is Taxol, docetaxel, which is Taxotere, pemetrexate, arenotaxel, Doxil, oxaliplatin, topotecan, basically 7 new drugs in 30 years compared to 1977. I mean, that was it, 16 plus 7. I mean, it was easy to get used to how these drugs work, their side effects, what the dosages were. Then they came out with capecitabine, which was an oral 5-FU. Then all of a sudden, for the first time, they came up with rituximab, which was an anti-CD20 antibody against CD20 that was found on lymphoma. But again, this was 2006. Let's go back to how you treated like breast cancer with hormone therapy. Up until 1977, you didn't have estrogen and progesterone receptors. So you looked at a patient and you tried to decide, should you start with hormone therapy or did you need to go straight to chemotherapy? And you looked at the patient, their age, how long it was from the initial surgery to the relapse. You looked at and decided whether or not they were in mortal danger, like with liver metastasis, versus was it just a couple of spots in their lungs and a few spots in their bone. So if it was just a non-immediately lethal therapy, you tried hormone therapy. And amazingly, the first treatment that you tried was very high dose estrogen therapy. And you went, and you must be saying to yourself, wait a minute, that's crazy. Estrogen makes breast cancer grow faster. Well, it turns out if you gave massive doses of this drug called diethylstilbestrol, you could actually shrink breast cancer metastases. And that would sometimes work for a year and a half. And when they started relapsing, the crazy part was you just stopped it and you had a rebound regression when you took it away. We also used progesterone drugs called Magestrol, androgenic drugs called halotestin. And we had many patients that we kept alive 3-4 years just on hormone therapy before they ever needed chemotherapy. In 1977, came along the drug tamoxifen. You all know it as an anti-estrogen. Around the same time, in the late 70s, estrogen and progesterone receptors became available. And then we knew who to give the drug to. If you had positive estrogen and progesterone receptors, you would probably respond 90% of the time to tamoxifen. If you didn't have those receptors, you never responded and you never gave those patients tamoxifen. It wasn't until 1995 that aromatase inhibitors came along that were better than tamoxifen. But again, at that time we then had tamoxifen and the aromatase inhibitors. For prostate cancer, up until 1985, if you had metastatic prostate cancer, you had bilateral orchidectomies to get rid of the testosterone that was coming out of your testicles. Leuprolide came along. It was an antigen deprivation therapy. You initially, back then, you got a shot once a month, then later every 3 months, and I think now it's every 6 months. And it basically did the same thing as getting rid of your testicles. It made your testosterone go to zero so that it would stop fertilizing the cancer to grow. It was not until 2011 that you got the drug abiraterone and then enzalutamide in 2012. And so now patients with metastatic prostate cancer, instead of dying quickly, will live for many, many, many years. What happened next? Well, all of a sudden they came up with a drug, or they found that breast cancer, some of the patients had HER2 new. So nowadays, every cancer is tested for ER, estrogen receptors, progesterone receptors, and HER2 new. And if a patient with breast cancer had HER2 new, they got this new antibody called trastuzumab, or Herceptin. But that was 1998. Imatinib, or Gleevec. It was the first tyrosine kinase inhibitor. Back in the days when I treated patients with chronic myelogenous leukemia, I would give them oral chemotherapy, and I could keep them alive maybe up to 3 or 4 years. If they were young enough and I could put them into remission, I sent them for bone marrow transplants that would cure them. But if you couldn't do that, in 3 or 4 years, you would go on to have acute myelogenous leukemia and die very rapidly. Well, all of a sudden, this drug Gleevec came along, and I remember I had a patient that I had on the list to have a allogeneic bone marrow transplant, and I canceled it and said, oh, let's try this new drug Gleevec. He went into complete remission and stayed in it until I retired in 2006, and I'm not sure what happened after that. But this was amazing because now they knew that there was something in the biochemistry of the cell that you could block and make a difference. Also, they discovered around 2004 that they never could say that. Avastin came along. It was an anti-VEGF treatment, anti-vascular endothelial growth factor. Basically, this drug stopped the cancer from growing because the cancer, as it grew, it needed new blood vessels, and this stopped the cancer from getting the blood vessels. Okay, so I retired in 2006, and since that time there has been an explosion of therapies called precision oncology. And almost all of the new drugs are in this type of thing. They're all drugs that are targeted to genetic mutations that drive tumor growth, also are targeted for molecular, biochemical, and genomic testing. As of 2015, over 201 new FDA-approved targeted and immune therapies. So, my entire career, 16 plus 7, 23 new drugs. Oncologists today now are looking at over 201 new drugs, and every month they're coming out with 2 or 3 or 4 new drugs. Literally, I've asked the oncologists today, how can you possibly keep up with this? And their answer is, it is very difficult, but we're now looking at artificial intelligence to help us with this. Okay, so we used to give chemotherapy and people used to get so horrifically, horribly sick, nausea, vomiting, 2, 3, 4 days. We used to give the drug Compazine or Phenergan, barely worked. Around 1978 or so, I was treating a couple of young men with Hodgkin's disease, and they came to me and they said, hey doc, we hear that marijuana can get rid of our nausea and vomiting. Would it be okay with you if we smoked a joint before we took our treatment? And having dabbled in marijuana myself back in the 60s, didn't scare me. I was giving people Demerol and morphine. I mean, I had no fear of marijuana, but I said to them, you just can't smoke it in my bathroom. You got to smoke it outside and come in. So after a month or two, I went to the two of them and I said, okay, now you've had 2 months of chemotherapy, 2 months of the marijuana, does it work? And they started laughing. And I said, why are you laughing? And they said, doc, we smoked a joint, we got stoned, we took the therapy, we threw up just as much, but because of the marijuana, we just didn't give a shit. And that was a true story. And at that point, because of it, out of the box, I started giving people some oral lorazepam or Ativan to have a similar effect, and it actually helped some. Around the early to mid 80s, a drug came along called Reglan or metoclopramide. Giving it along with high dose of dexamethasone, it actually did cut down on the less nauseating chemotherapy regimens. The problem was the metoclopramide or Reglan, as many of you internal medicine residents know, can cause akathisias, which are movements, and so we had to be very careful as we gave it. So it was not until 1991 that Zofran, ondansetron, came along, and this was miraculous. I mean, all of a sudden, we were giving people chemotherapy, even the red devil, Adriamycin, and they were coming back in and saying, doc, it's unbelievable, I never threw up. I mean, it was the only miraculous. It was life-changing for oncology. Up until this time, when we gave patients aggressive chemotherapy, they would have severe neutropenia for 5 to 7 days, and during that time, they would be very susceptible to infection and to sepsis. The infections usually didn't come from the outside, but from their GI tracts and their GU tracts. And all of a sudden there was this drug that we could start after giving a treatment. You had to wait a day or two. And all of a sudden the low white count, the neutropenia, only lasted a day or two instead of 5 to 7 days. And all of a sudden there was very few cases of sepsis. Then came along a drug in 2002 called Neulasta that was long-acting Neupogen, and the patient got a shot the next day instead of every day. And again, sepsis and admissions for infection almost disappeared. The other thing was patients on chemotherapy had severe anemia, hemoglobins of 9 and 8. It wasn't until 1989 that Procrit or Evogen came along, and suddenly you could give an injection and bring their hemoglobin up to 12 or 13. After the nausea and vomiting and chemotherapy got controlled, patients started complaining of chemo brain or brain fog. Up until then, they were so sick from chemotherapy that they didn't even talk about it. So again, out of the box, I thought, gee, if you're sleeping all the time and you're fatigued and your brain's not working right, I wonder if a stimulant, methylphenidate or Ritalin or now Concerta, I wondered if anybody would get better. So I started giving patients Ritalin, and I had to write on the prescription, this is for chemotherapy-induced narcolepsy, because only narcolepsy was allowed to give people Ritalin at that time. It was before the days of ADHD. And nobody ever came back at me on it. And lo and behold, 90% of the patients would come in 1 month later and say, Doc, thank you for giving me back my life. I'm back working. I'm back being a wife. I'm back being a mother. 10% of the patients came in and said, it made me worse. So I thought about that and I said, why did that happen? So I started asking patients about their personality prior to getting cancer. And I realized that 10% that got worse on the Ritalin were ADHD. And so I slowed them down with the Ritalin. But the 90% that were in ADHD, they had improvement to the stimulant. Okay, what else has happened over the last years? Going back to the 1960s, we only could diagnose brain and liver metastasis using ultrasound, very imprecise. It was not until the early 1970s that nuclear scans came along for brain, bone, and liver. I mean, up until then, if you wanted to know if a patient had bone metastasis, you did a total body bone survey and you looked for osteolytic or osteoblastic metastasis. But then suddenly nuclear scans came along and we were seeing things we never had seen before. It wasn't, and this is, I think you'll find that amazing, it wasn't until late 1970s the CAT scans, computerized axial tomography of the brain, the lung, the abdomen, the pelvis came along. It wasn't until the late 1980s that MRIs came along. And just when I was retiring, PET scans, positive emission tomography, came along in around 2005, and this dramatically changed how you could stage a patient. Prior to PET scans, there were many patients that we thought had stage 1 disease at the time of surgery, and lo and behold, PET scans said they already had stage 4 disease. The other improvements in radiology was CT-guided biopsies, ablations, intra-arterial chemotherapy. The radiologist became a very, very important part of the team of cancer care to this day. Further improvements. Let's talk about pathology or pathologists. Until just recently, patients would come in with metastatic disease, but we didn't know where it started. They were called cancers of unknown origin, 10 to 15%. The pathologists did the best they could looking at the cancer biopsy using H&E stains, but they still couldn't tell in 10 or 15% of the time. Sometimes they would send it off for electron microscopy. But today, there are special stains the pathologists use that didn't exist back until probably the last 10 or 15 years. And because of that, almost all cancers now, even a metastasis, you can then kind of really narrow down where it started. And again, because of MRIs and PET scans, now you're doing, almost never do you have a cancer of unknown origin. In the old days, patients with lymphomas and leukemias we would just have to look at the bone marrows. We would look at the peripheral smears. Now you have flow cytometry that tells you what you're dealing with. Also, you could send blood off for genetic analysis, which has only come about just recently. Okay, in the beginning, I, in my office, perform many procedures that today are done in hospitals by radiologists. When I gave this talk a couple of weeks ago, the one person in the audience kept gasping, knowing what I was doing in my office. I would have just an assistant, sometimes a nurse, sometimes my wife worked with me and she helped me. In the office, I would do bone marrow aspirates and biopsies, very painful procedures. Because I watched colonoscopies during my residency being done with Valium and Demerol, I thought, gee, why don't I just give a little Valium Demerol, put somebody to sleep for about 10 minutes, do the bone marrow, and when they woke up, they wouldn't be mad at me for hurting them. And lo and behold, patients would wake up and say, Doc, when are you going to do the procedure? And I would say, oh, it's finished 5 minutes ago. So I routinely did what is now called conscious sedation. Now, in 2025, if you're going to do conscious sedation, you're going to have an anesthesiologist, you're going to have EKG leads, you're going to have a pulse ox on the patient, and it's going to cost $400 to have the anesthesiologist. I gave it for $10 in my office. Subclavian catheters. Well, back in, say, 77, my nurses would come to me after a few months and say, Dr. Sternberg, we can't find the vein to give this chemotherapy. And so I had been trained at MD Anderson how to place subclavian catheters, which is usually done by surgeons. We used to use a thing called intravenous hyperammontation to feed patients. Now it's called total parenteral nutrition. But you had to be able to place a subclavian catheter to do it. So I got pretty skilled in it. And so when a nurse would tell me that, I would bring the patient into the exam room. I would put their feet at the head of the exam table, their head at the bottom where feet usually go. I would lift up the head of the table to make the subclavian vein larger. And in my office, I would place a subclavian catheter using this tray that we bought. Sometimes I would do 2 or 3 a day. We would then send the patient we had x-ray in my office to make sure there was no pneumothorax. I was able to put these in 5 to 7 minutes, skin to skin. My favorite story was I was treating a radiotherapist for breast cancer, and I was very honored that she chose me over all the other oncologists by that point. And I told her I would treat her just like any other patient because I had noticed that VIPs got lousier treatments, and I was going to treat her just like everybody else. So she needed to have a subclavian. So I bring her in the room. Her husband came in with her. He's sitting in a chair at the foot of the table. And as I'm doing it, I look over at him and I say, by the way, what do you do for a living? And he said, I'm a surgical oncologist at the Med Center. And I thought, oh, this poor man. Here I am, an internal medicine oncologist, putting a subclavian catheter in his wife, and he's a surgical oncologist. And when I got all done in 7 minutes, all he said was, damn. I mean, he was just in shock at how fast I could do it. But that one, again, is one of my favorite stories because, again, it wasn't until the mid-1980s that infuser ports came along and surgeons put them in, and so I didn't have to do subclavian catheters. But we used to put these in and teach the patient how to flush them and how to take care of them, and they would stay in 2, 3, 4 months just like infuser ports would stay in. I mean, crazy today, but that's all we had back then. Also, patients would come in, they'd be short of breath, I'd get an x-ray, they would have a large pleural effusion on either one or both sides. And so we would bring him into the room. I had a disposable tray. I would tap them with my finger. I would figure out where to stick the needle. I had a catheter, a soft catheter that I would then thread. And we had these vacuum bottles, and we would suck off whatever was needed. Here's 2,000 cc's of bloody pleural effusion. And that would be the end of it. I would send them for an x-ray afterwards, and we would give them their chemo that day. I mean, today, the radiologist, you send the patient to the hospital to have this done. I did this for $150. Now it's thousands of dollars. Patients needed to have a lumbar puncture spinal tap to diagnose whether they had leptomeningeal carcinomatosis, cancer in the spinal fluid. Also to give them intrathecal chemotherapy, meaning putting chemotherapy into the spinal fluid. So again, we bring the patient into the exam room. My assistant, we'd scrunch them up in a ball, fetal position. And in my office, I did spinal taps. We would send the fluid off. I would have them draw out the chemotherapy. And the regimen was intrathecal once a week for 4 weeks. I would do spinal taps in the office. Again, we're talking under 10 minutes. We didn't send patients to the hospital to get spinal taps. I also did paracentesis for ascites in the office. I mean, literally everything was done in the office. As I said, many of these procedures are now done by radiologists. Bone marrow sedation is done sometimes with the Valium and Demerol, all of these things. But the other thing that happened was we used to do inpatient infusional 5-FU chemotherapy. We would admit the patient to the hospital, and they would get 5-FU continuously over 5 days, and this was very effective for many cancers. So, all of a sudden, they came up with this, and this was rudimentary, but we would put 5 days of chemotherapy of the 5-FU into a syringe. They came up with this little machine, and this is actually not as crude and rudimentary as the first ones we used. And we would set the machine at a certain rate, and it would plunge the plunger on the syringe, and it would take 5 days to go in to the subclavian catheter that I had already placed in the patient. Then later came along computerized things like this, and it was much more sophisticated, but it really didn't work any better. Now, today, we don't do 5-FU infusion therapy anymore because a drug called Zolota or capecitabine given orally can do the exact same thing. When patients stopped throwing up, they complained about their hair loss. So somebody came up with the idea, well, gee, if you constrict the arteries to the scalp, maybe not as much chemotherapy will get there, and patients won't lose their hair. So we went out and bought a whole bunch of these ice caps. We went out and bought a freezer, and each patient, we would try to save their hair with this. And in many of the regimens, it was quite successful. And then for some reason, it fell out of favor, and guess what? Now it's back in favor, but now you have this.
Would you join me in word of prayer? John 15, verse 5. I am the vine, you are the branches.
Who is this?
You remain in me, and I in you. You will bear much fruit. Apart of me, you can do nothing.
We do it every
We talk about fruit. We're talking
So anyway, now if people use it, now they use
love,
these.
joy, peace, patience, kindness, goodness, faithfulness, gentleness, and self-control. That's how we know that we belong to Him. We bear the fruit. So I commit our staff, our patients, and their families, and our volunteers to you, Lord, knowing that you're going to allow them to experience the fruit of your Spirit. We rejoice because of you. In Jesus' name, amen.
Amen. And so now today, if a doctor wants to do it, there's this fancy machine instead of needing freezers. Lastly, let's talk about hospice, death with dignity. I'm almost done. 1967, first hospice was St. Christopher's in London, England. 1969, Dr. Elizabeth Kubler-Ross came up with the 5 stages of death and dying. In 1981, I lost a 30-year-old patient to inflammatory breast cancer that she developed during a pregnancy. Her husband desperately wanted to do something to honor her memory. I talked to him, I said, you know, I've been reading about this thing called hospice. We don't have any in Arkansas or really in the United States. So in 1982, we came up with a thing called Partners of Patients in Little Rock. It was actually the first hospice in Arkansas. It was funded by donations because in those days insurance didn't pay back or didn't pay for hospice. And of course, it's now covered by all insurances, Blue Cross, Blue Shield, Medicare, everybody, because they realize instead of patients dying in the hospital expensively, they can now die at home and they can save money. That's their motivation, but what's the difference? They're at least paying for it. Okay, so what are my personal conclusions about what's happened in my career? Cancer care has made enormous strides in the last 48 years. There's increased disease-free survival, increased remissions, increased cures, increased stabilizations. It was exciting to be in the new frontier of medicine, being a pioneer. But delivering cancer care was and is overwhelmingly exhausting. Cancer care challenges you intellectually, especially since it's now changing so rapidly. Cancer care tires you physically with its long hours. Cancer care drains you emotionally due to all the suffering and the dying of your patients. And I used to have a thing on the wall that I would look at frequently called the physician's lament, and this goes for even if you're not a medical oncologist. Some days I get tired of taking care of other people's problems. Some days I'm grateful they're not mine. Some days I feel great and I could cure the world. And some days I just don't feel anything at all. Thank you for listening to me. I hope you've enjoyed the history of oncology in Arkansas.